Good afternoon, everybody. So today we are about to start our webinar. Our topic is nerve block, LOR and PNS guided nerve blocks for the surgery on head and neck region. So in this, we'll cover the three blocks, mainly superficial and deep cervical plexus block, and mandibular nerve block, and scalp block. So all these three blocks mainly will utilize for a as a part of multimodal analgesia for head and neck surgery, along with general anesthesia or along with any other kind of anesthesia with sedation or thing. So it's not we can't use all this block as a sole anesthetic technique, but we can use as a multimodal analgesia or as a part of post-op analgesia after surgery. So our today's presenter is Dr. Anil Kumar. He is working as a freelancer anesthetist in Kakinada city of Andhra Pradesh. And he is very dynamic and young anesthetist, and he is very enthusiastic to present teaching and for teaching and learning purpose. And his hobby is to serve the knowledge amongst the anesthetists to uplift our fraternity. So I'm heartily welcoming Dr. Anil Kumar sir. And yeah, now I'm handing over today's session to Dr. Anil Kumar sir to present the webinar on LOR and PNS landmark guided and PNS guided block on head and neck block for head and neck surgeries. Okay, session handed over to Dr. Anil Kumar sir.
Yeah, is the video is visible and audio is visible, Hitesh?
Audio is not visible, sir.
Audio is
sorry, not video. Video is not visible. I can hear you, but your video is not coming.
1 minute.
You can start your video.
Yeah, I'm starting the PPT, but share.
You can on your camera. Initially, yeah. Now I can see you. Yeah. Now I can see your PPT also.
Yeah. So, good afternoon, everyone. We will now discuss about scalp block and the superficial and deep block and the mandibular nerve block. So, I'm Dr. Anil Kumar. Thank you, Dr.
Everyone, please mute yourself.
Am I audible right now?
Yeah, you are audible. You can continue.
So, coming to scalp block. Coming to scalp block. Somewhat little bit disturbance is there. Please, can you unmute?
Yeah. Please unmute your. I'll unmute all participants. Wait.
So coming to scalp block can be used for both surgical and pain management purposes. So the nerves are around 6 nerves we have to block in the scalp block, mostly from the trigeminal nerve and the cervical. We all know that scalp is very highly vascular, and so for every injection we must negatively aspirate, and because of inadvertent injection to the blood vessels, because all the nerves are associated with the many blood vessels, as we all know that the scalp has a lot of vascular supply, so there will be a chance of inadvertent injection. So during the scalp block, we must be very careful. So we must do the negative aspiration before giving any type of the block to any nerves. So mostly the complications in the skull block include sometimes direct nerve damage and injections into blood vessels, which closely accompany the nerves. So the scalp is, we all know, is a soft tissue which covers the cranial wall, excluding the facial bones. The scalp has 5 layers. We all know that it has skin, connective tissue, aponeurosis, and loose areolar tissue and periosteum. So the trigeminal nerve and the spinal nerve, the cervical spinal nerves, which form the superficial cervical plexus, they all provide the sensory innervation to the scalp through 6 different nerves. I will explain you briefly in the diagrams and coming pictures in next slides. So the ophthalmic, maxillary, and mandibular branches of trigeminal nerve supply the anterior skull, whereas the greater and lesser occipital nerve supply the posterior skull behind the ear. So coming to what are the indications of the skull block? Why we use the skull block? Mostly during the awake craniotomy procedures, or it can be given as an adjunct to general anesthesia, because so that we can reduce the doses of anesthetic doses when we are going for a supratentorial and infratentorial craniotomies, and we can use for the perioperative analgesias. So this skull block can be also used in the plastic surgeries also for the repair of lacerations, plastic surgery procedures like anterior skull pigmented nevus, and some in pain management also we can give for neuralgias and cluster headaches, and even we can give for post lumbar puncture headache also. The skull block can be used. So what are the contraindications of the skull block? The most proven contraindication, absolute contraindication, is the allergy to local anesthetic, and if sometimes there will be craniectomies will be done. So if craniectomy is done, so if we give skull block, sometimes we inadvertently give injection to the subarachnoid thing and subdural thing. So if the craniectomy is done, if there is no bone flap is there, so it is necessary to avoid the skull block if the craniectomy, post craniectomy patients. And related indications include contraindications include if there is any local site infection, if there is some bleeding disorder, if there is a scarring due to previous craniotomy, because if this scarring is there, we can't able to assess the nerves properly. There will be anatomical malformations will be there during scarring. So what are the nerves we will block in the skull block? So we generally 6 nerves on both sides. There are supratrochlear and supraorbital nerves, and auriculotemporal nerve, zygomaticotemporal nerve, and lesser and greater occipital nerve, and sometimes we will block great auricular nerves. So coming to supratrochlear and supraorbital nerves. So these arise from the frontal nerve, which is again a branch of the mandibular nerve, which comes through the orbit. So if you are able to see the video, so here the frontal nerve is arises from the superorbital fissure, and from the medial aspect of superorbital fissure, and it comes into the orbit and it divides into lateral supraorbital nerve and medial supratrochlear nerve. The supraorbital nerve travels anteriorly above the levator palpebrae superioris and exit the orbit through supraorbital notch. You can see here the supraorbital nerve is exiting from the orbit through supraorbital notch, and immediately you can see the supratrochlear nerve. So coming to zygomaticotemporal nerve, it innervates the small area of the forehead and the temporal region. It originates from the maxillary branch of trigeminal nerve. It passes through a small canal in the zygomatic bone. You can see this is a zygomatic nerve. It can passes through small canal in the zygomatic bone, and it enters into the temporal fossa, and it lies between the temporalis muscle and the bone, temporal bone. So it arises midway between supraorbital and auriculotemporal nerves. So auriculotemporal nerve, it innervates the temporal areas, lower lip, lower face, auricle and scalp above the auricle. It arises as 2 roots from posterior division of mandibular branch of the trigeminal nerve. And this nerve process of the root of zygomatic process of temporal bone and lies posterior to superior superficial temporal artery. Coming to this is the auriculotemporal nerve. These are all the anatomical landmarks I'm telling, and I will tell and explain in coming slides in a very summarized way. So the other 2 nerves which are supplying the posterior part of the skull and the occipital nerves, which originate from the cervical spinal nerve C2 and C3. They are located in the posterior neck and scalp region. The two nerves are greater occipital nerve, which runs between obliquus capitis inferior and semispinalis capitis muscle. So here we can see in the right image. So this is the greater occipital nerve, which passes between the semispinalis capitis and this obliquus capitis inferior muscle. So after piercing the semispinalis capitis muscle, it enters into the scalp, posterior part of the scalp, and it runs along with the occipital artery and it supplies the posterior part of the scalp. And as well as lesser occipital nerve, it runs superiorly towards the skull along the posterior aspect of sternocleidomastoid muscle. So here the lesser occipital nerve passes to the posterior aspect of the sternocleidomastoid muscle and it enters the posterior part of the scalp and it supplies the posterior aspect of the scalp. The scalp block has been reported to include an additional nerve called great auricular nerve. This is the great auricular nerve is the greater trunk or largest trunk of the ascending branches of cervical plexus. It arises from C2 and C3 nerves. This posterior branch supplies the skin of mastoid process and part of the back of the auricle. So coming to the technique. So in the technique we used in scalp block, we first disinfect the scalp. We have to use the sterile gloves and gauze piece. We require a 10 ml syringe and local anesthesia drugs. Generally, we use general anesthesia drugs including 0.25% bupivacaine or 0.75% ropivacaine. Mostly 0.75% ropivacaine I am using here for a long-acting purpose. So addition of epinephrine or not adding epinephrine is of your choice. But addition of epinephrine will cause the vasoconstriction. It limits the systemic absorption of local anesthetic in intensely vascular areas like scalp. So the volume of local anesthesia administered at injection each side is mostly around 2 to 5 ml, not more than 5 ml. Even though if you increase the volume, it will have another type of complication. So what are the injection points here? So you can see for the supraorbital and supratrochlear nerve, the injection point is above the supraorbital margin, and the zygomatic-temporal nerve is here, the auriculotemporal and the greater occipital and lesser occipital. So coming to the technique, and I will explain it here. So first of all, in any technique, in any block, you must take the informed consent. You must explain the patient about the block, the procedure, and what you are doing. Because if it is an awake craniotomy, the patient is awake. So you must explain to the patient. And for surgical patients, this block can be performed after induction because somewhat it will be painful. And as a general anesthesia or end of the surgery for post-operative analgesia, the patient lies here in supine on the table while the performing operator, you usually stands at the head end facing the feet. The sedation is recommended during administration of the block as it can be painful. Most of the injections are superficial subcutaneous injection. You should produce a wheal on injection. So gentle massage after injection with a piece of gauze help in the spread of local anesthesia. So coming to each nerve block, you will see here the supraorbital nerve. So when you're seeing the image or when you're seeing the thing, the yellow area of this forehead, this anterior forehead is supplied by the supraorbital nerve, and the medial side, which is covered by the white one, is a supratrochlear nerve supplying area. So this fellow has a little bit small laceration on his anterior forehead. So I want to perform a supraorbital nerve block for him. So we can avoid a lot of injections for this suture. Simply depositing around 2 to 3 ml or 2 to 4 ml in the supraorbital notch, medial to supraorbital notch, it will give excellent anesthesia and analgesia for this suture lining. So by blocking the supraorbital nerve. So for the supraorbital nerve, this block is performed with the patient's head facing towards forward and eyes closed. The supraorbital nerve can be blocked as it exists through the orbit. So coming to this is the supraorbital notch. Here what you will see is the supraorbital nerve is existing through the supraorbital notch, and it supplies the anterior and the superior part of the forehead, anterior supply of the forehead and the skull. So this is the supraorbital nerve which originates from the frontal nerve. So this is, are you able to see? And so for blocking the supraorbital nerve, so nearly 2 to 3 ml of local anesthesia is enough to get a complete anesthesia for that area. which is supplied by supraorbital nerve. The supraorbital, you must identify the supraorbital notch, and supraorbital notch is easily identified, even though the obese patients also it are easily identified by palpation. And the needle is introduced perpendicularly 1 centimeter medial to the supraorbital notch. So here is the supraorbital notch, and you inject medial just 1 centimeter medial to the supraorbital notch. You just go perpendicularly, hit the bone, and just inject anesthesia there. Around 2 to 3 ml is enough to block the supraorbital nerve. So here we are injecting around 2 to 3 ml of local anesthesia medial to the 1 centimeter medial to the supraorbital notch, which can anesthetize the supraorbital nerve block. So the patient can be easily sutured by giving just 2 ml of local anesthetic. We cannot use local infiltration is not required like the surgeon, but we like the anesthetist, we can give around 2 ml, just 2 ml, just to a medial to supraorbital notch, and we can give the supraorbital block anesthesia. So coming to the supratrochlear nerve. The supratrochlear nerve also, you can see that so medial to the supraorbital nerve, it is the supratrochlear nerve, which passes through the supraorbital margin. So after giving the supraorbital nerve, keep the needle in the same place, and just in the same position only, the needle is directed medially to the same insertion point. The subcutaneous injection of 2 to 3 ml here will be blocked the supratrochlear nerve. So here, so you can see when you inject within the same insertion point, just redirect the needle and give infiltrate the local anesthesia very superficially, so that you will get a bleb also. This skin wheel is also present. Bleb will also occur. It's just around 2 ml of local anesthesia required to block the supratrochlear nerve. So you can block supraorbital nerve and supratrochlear nerve by just one insertion point. After hitting the bone and giving the 2 to 3 ml of local anesthesia, and you can block the supraorbital nerve, and you just redirect the needle and go medially and just infiltrate 2 to 3 ml of local anesthetic drug. So you can see this in image. There will be rise of this local bleb will occur here. So the supratrochlear nerve will be blocked. So I from this app, and I rounded the figure of supratrochlear nerve so that you can easily understand that. So coming to zygomaticotemporal nerve, this block is performed with the patient's head turned to one side to be the block faced upwards. The zygomaticotemporal nerve ramifies, and as it pierces the temporalis fascia, hence both subcutaneous and deep injections are needed to block the zygomaticotemporal nerve. So even though we can block the deep, there is deep and superficial injections, here also very little amount of local anesthesia required, not more amount of local anesthesia, just around 2 to 5 ml of local anesthesia required even to block the zygomaticotemporal nerve. So here you can see the zygomaticotemporal nerve, the insertion site. So you can easily understand when I make you see this image. So what is happening here? So zygomaticotemporal nerve is another branch for maxillary nerve branch division of trigeminal nerve. It originates from the angle between the zygoma bone and supraorbital margin. So you just at the junction of the supraorbital margin and the zygoma, you just insert the needle and hit the bone, and you just insert and give 1 to 2 ml of local anesthesia here as a deep injection, and coming and taking out the needle, you can deposit around 3 to 4 ml of local anesthesia superficially, so you can get the bleb. So you can go hit the needle and deposit 2 ml of anesthesia, come out of needle, take out the needle and create a bleb over there at the junction of the supraorbital margin and the zygoma. So the needle, I pointed out the zygomatic nerve and circled this thing, so you can easily understand. So your injection point is perpendicular to the junction between the supraorbital margin and the zygoma. So where the zygomaticotemporal nerve is originated, so that nerve can be easily blocked. So coming to auriculotemporal nerve, the position of this block is similar to zygomaticotemporal block. And here the easy process is
here
the easy process. Yeah. So here the easy process, you should find a tragus from the anti-tragus. It's around 3 to 4 centimeters anterior to the tragus. You will find the pulsations of the temporal artery. So by pulsating temporal artery, you must palpate the temporal artery and just half centimeter medial to temporal artery, just insert the needle like this and go posteriorly to the temporal artery. So this auricular temporal nerve lies posterior to temporal artery. So just deposit 2 to 3 ml there. The auricular temporal nerve will get blocked. So here the nerve can be blocked by injecting around approximately 3 ml of local anesthetic, 1 to 1.5 centimeter anterior to the ear at the level of tragus, above the level of temporomandibular joint. The easy identification is you must palpate the superficial temporal artery and go posterior to the superficial temporal artery. So sometimes the complications may be, if you don't aspirate, you may inject into the superficial temporal artery. So negative aspiration must be compulsory for this auricular temporal nerve block. The injection is superficial and subcutaneous, as deep line injection can cause facial nerve block also. So you must explain the complications to this patient also if you are going for an awake craniotomy or for a pain procedure. So this is the auricular temporal. So again here I draw the point of needle insertion. You can go perpendicularly by palpating the temporal artery, hit the bone and give the local anesthesia 2 to 3 ml. So coming to greater occipital nerve. So greater occipital nerve and lesser occipital nerve, these two nerves supply the posterior aspect of this skull. So this greater occipital nerve can be performed by turning the head to the side or making the patient sitting up. The greater occipital nerve can be blocked by infiltrating local anesthesia subcutaneously. So the best landmark you can see here. So greater occipital nerve, you can draw the line between the occipital protuberance, the mastoid process. So in this line, so nearly 2.5 centimeters lateral or towards the posterior end, you can find the pulsating occipital artery. So by pulsating occipital artery, inject the local anesthetic, hit the vocal line just medial to the pulsating occipital artery and inject 2 to 3 ml of local anesthesia there. You can block the greater occipital nerve. And for lesser occipital nerve, just medial to the where the insertion for the greater occipital nerve, you can go for the lesser occipital nerve also. You can block here. Both are in the superior nuchal line only. So first of all, what you will see is how you point out the positions are. You must identify the mastoid process first, and then you must identify the occipital protuberance and draw a line in between. So mostly from the mastoid process, it is around a 2/3 distance, greater occipital nerve, and 1/3 distance, it is the lesser occipital nerve. So the greater occipital nerve, it can be easily given in another way by palpating the occipital artery here, and just medial 1 centimeter medial to occipital artery, you just insert the needle, just hit the bone and deposit there. 2 to 3 ml is required to anesthetize the greater occipital nerve. And for the lesser occipital nerve, from the mastoid process, just around 1/3 distance to the occipital protuberance line on the line, you can directly hit the bone, just withdraw and then deposit around 2 to 3 ml of local anesthesia there. So another thing is great auricular nerve. So sometimes we must anesthetize this great auricular nerve also. These posterior branches of great auricular nerve must be blocked. This is the largest branch of cervical plexus. So this can be blocked by in the mastoid process. You hit the mastoid process and just deposit subcutaneously 2 to 3 ml. You can easily block the great auricular nerve. So coming to the skull block, so you must know the anatomy. So I want to again revise it in a very few seconds so that you will never forget. So coming to the anatomy, this is the supraorbital nerve and the supratrochlear nerve. These two nerves are present in the supraorbital margin. Very easy to identify the supraorbital notch by palpating the supraorbital margin. Very little bit depression is there. So if you find a little bit depression, that is called supraorbital notch on the supraorbital margin. Just 1 centimeter medial or 1 centimeter medial to supraorbital notch. Just deposit 2 to 3 ml of local anesthesia by hitting the bone perpendicularly. So like this, and you will block the supraorbital nerve. In the same side, don't withdraw the needle. You go medially and deposit subcutaneously. Deposit subcutaneously in the same from the same point of insertion. You will block supratrochlear nerve. You create a bleb over there. Just create a bleb over there in the supraorbital margin like this. So then you will definitely infiltrate the supratrochlear nerve. So it's very easy injections, supraorbital and the supratrochlear nerve. And for zygomatic temporal, you must identify the angle between the supraorbital margin and the zygomatic. And in that angle, you just pierce the needle, hit the bone, deposit 3 ml of local anesthesia there. When you retracting the needle, give another 2 to 3 ml of local anesthesia by creating a bleb over there, so that you can anesthetize both superficial and the deep branches of the zygomaticotemporal nerve, because the zygomaticotemporal nerve ramifies in the temporalis fascia. Coming to auricular temporal nerve, you must feel the temporal artery and just 1 centimeter medial to temporal artery, go perpendicularly, hit the bone. This auricular temporal nerve present posterior to the temporal artery. So when you hit the bone, just what you will do is redirect the needle posterior to the temporal artery and deposit 2 to 3 ml of local anesthesia. Before depositing, just aspirate. Negative aspiration must in this injection, because temporal artery is present very nearly to this auriculotemporal nerve. So I mark the entry point. Just anterior to the tragus, you must enter very perpendicularly by palpating the temporal artery pulsations and go posterior to temporal artery and deposit 2 to 3 ml of local anesthesia. You will block the auriculotemporal nerve. And for greater occipital and lesser occipital, I have discussed, like you must draw a line between the mastoid process and the occipital protuberance. So in this line, 2/3 distance from the mastoid process, you will hit the bone and inject 2 to 3 ml of local anesthesia. You will block the greater occipital, and 1/3 from the mastoid process, you will deposit around, hit the bone and deposit 2 to 3 ml. You will block the lesser occipital nerve, and on the mastoid process, create a wheel by infiltrating the subcutaneously by hitting the bone. You will block the greater auricular nerve. So these are the techniques for the skull block. The most complications in the skull block is anaphylaxis in response to local anesthesia. There will be toxicity of local anesthesia if you inadvertently inject into the blood vessels, because the scalp is very vascular. Before each injection, you must what you will do is negative aspiration should be there. If there is so every injection you should aspirate and you should give, because the scalp is very vascular. There will be high chances of getting the systemic toxicity, and vascular injury and hematoma formation is also a complication in the skull block. Sometimes there is a complication of facial nerve palsy is present. If you go for auricular temporal nerve, if you go more inside, more deeper, you may anesthetize the facial nerve, but it is also temporary one, not a permanent one. You should assure the patient that he will get back the nerve after waning of anesthesia. So sometimes in the craniectomy patients, sports craniectomy patients, what will happen is there is no bone flap. If you don't find the bone flap, if you not hit the bone, the skull block is mostly contraindicated in that patients. What will happen is, if you don't have hit the bone, if there is no bone flap there, if you gave the injection, you mostly intracerebral and subarachnoid injection will take place. This has been reported in patients with bony defects or previous craniectomies. Sometimes you will get a trigeminal cardiac reflex. That means you will get if you're blocking the trigeminal nerve, you will get a bradycardia and hypotension. Very rarely infection will be there. These are the complications of this skull block. So coming to cervical plexus block. So cervical plexus block is the mostly done procedure for even though for the upper limb surgeries also interscalene block accompanied with the superficial cervical plexus block to cover all the nerves. So we don't want to miss the nerve. So this is the in the freelance anesthesia. These are the uh, common techniques we use daily. Superficial cervical plexus and deep cervical plexus we will use rarely, but in institute like things we can use deep cervical plexus block also. What will happen in deep cervical plexus means sometimes you can paralyze the phrenic nerve also. So for in the deep cervical plexus block, when you are giving deep cervical plexus, you must see that the patient is not respiratorily compromised patient, and he must be healthy patient, so that even though you block the phrenic nerve, that patient will not get any respiratory compromise. So for the what are the indications and contraindications of this cervical? So deep and superficial cervical plexus blocks can be used in variety of surgical procedures, including superficial surgery of the neck and shoulders and thyroid surgery also. It is used most commonly in carotid endarterectomy, in which awake patient self-monitors to ensure adequate cerebral blood flow during cross-clamping of the carotid artery. So this is the carotid endarterectomy surgery, which was done under cervical plexus. Both superficial cervical plexus and deep cervical plexus, both block will be do, and it is in awake patient. It is a carotid endarterectomy by just blocking the superficial and deep cervical plexus. So what are the contraindications for superficial and deep cervical plexus? It is a patient refusal, if there is an infection locally, if there is a radiation therapy to the neck, and due to the risk of phrenic nerve, as I said earlier, there is a risk of phrenic nerve paralysis will be there. The deep cervical plexus block is relatively contraindicated in patient with contralateral phrenic nerve palsy or significant pulmonary compromise or COPD patients. You must avoid the deep cervical plexus. So coming to functional anatomy of deep cervical plexus. So first we will discuss about the technique of deep cervical plexus block, and then we will discuss about the technique of superficial cervical plexus block. Both blocks are very easy to perform, very easy to learn, and the cervical plexus is formed by anterior divisions of 4 upper cervical nerves, and the plexus is situated on the anterior surface of 4 upper cervical vertebrae, resting on the levator angulis scapulae and scalenus medius muscles. It is covered by the sternocleidomastoid. So, if you block the superficial cervical plexus, you can anesthetize the skin and superficial structures of the head, neck, and shoulder. And if you anesthetize the deep cervical plexus, you can anesthetize the structures including muscles of anterior neck and diaphragm, which is innervated by the phrenic nerve. So by combining the both superficial and deep cervical plexus, you can perform in anterolateral neck surgeries also. Sometimes, in addition, the surgeon should infiltrate local anesthesia because it is a complex anatomy of superficial and deep cervical plexus. Even though you give very accurately, sometimes there will be the block is inappropriate. Some regions will be spared where the surgeons should know anatomy and infiltrate locally. So coming to the landmarks of deep cervical plexus block, you must identify the 3 things. First is the mastoid process, and another one is the transverse process of 6 cervical vertebrae, and third one is the posterior board of the sternocleidomastoid. So here, what I doing is what we do is first we have to identify the transverse process of C6 vertebrae, chestnut tubercle, and then draw a line between the mastoid process and the C6 vertebra. So so this is the cervical vertebra. So this is this point. What I what is this marked is this is chestnut tubercle, this is C6 vertebra, and this is the mastoid process. This is the line, and from the mastoid process, for every 2 centimeters, you must mark the points like C2, C3, C4, and C6 for deep cervical plexus. This diagram is about the superficial cervical plexus. For the easy identification of the landmarks, I have kept this picture. So after identification of the C6 vertebra, which is the most important thing in deep cervical plexus block, you must draw a line between C6 vertebra and the mastoid process. And the transverse process of C6 is usually palpated behind the clavicular head of sternocleidomastoid, the level just below the cricoid cartilage. Next, a line is drawn connecting the mastoid process to chachesnoid tubercle and positioning the palpating hand just behind the posterior border of sternocleidomastoid. Once this line is drawn, label the insertion sites for the C2, C3, C4, which are respectively located on mastoid process to C6 line, 2 cm, 4 cm, and 6 cm, caudal to the mastoid process. So equipment is a regular, like a very regional anesthesia equipment we must keep with us. The technique is you must clean the skin with the antiseptic solution. Local anesthesia is infiltrated subcutaneously along the line. And the needle is inserted between the palpating fingers an angle perpendicular to the skin. So you must go perpendicular to the skin, hit the transverse process, come back a little bit, and inject 4 ml of local anesthesia after negative aspiration of the blood. So do the same procedure in the 3 levels, C2, C4, and C6 for the deep cervical plexus. So for deep cervical plexus, you must inject in the 3 sites, C2, C4, and C6. So you will get a deep cervical plexus block there. So the transverse process is typically contacted at a depth of 1 to 2 centimeter in most patients. So more than 2.5 centimeter, if you go inside, there is a risk of spinal cord injury. So onset of the block is around 10 to 15 minutes. The first sign of onset is decreased sensation and distribution of cervical plexus. So as I said earlier, this because of the complex arrangement, the juvenile coverage of various layers in the neck area as well as cross coverage from the contralateral side, anesthesia achieved in cervical block, sometimes some parts are spared, some area of the neck is spared, where we can surgeon can accommodate with the local infiltration. But the perfectly we can do the surgeries by using the superficial and deep cervical plexus block. For this deep cervical plexus block, you must insert the needle in the 3 sites along the line from mastoid process to C6 chachesnoid tubercle. This is the mastoid process and this is C6 tubercle. You must identify 2 centimeter, 4 centimeter, and 6 centimeter. In each transverse process, C2, C4, and C6, you must hit the transverse process, come back, deposit 2 to 4 ml, and in the C4, hit the transverse process, come back, deposit 4 ml. C6 again, hit the transfer process and little bit withdraw and deposit 4 ml. Will definitely get the deep cervical plexus block within 10 to 15 minutes. So coming to superficial cervical plexus block, it's very easy. So here what you will do is the same line is present. Here you must see the same line is present. That is from this is the gray line is the mastoid process, and this blue line is mastoid process, and the gray line is the clavicular end, and this is the round line which is not colored is the chachesnoid tubercle. So in between the chachesnoid tubercle and the mastoid process, the midpoint you must take. This midpoint is the needle insertion for the superficial cervical plexus. So it's very superficial. You must enter posterior to the sternocleidomastoid muscle. So initial injection with it is very superficial. The site of needle insertion is marked at the midpoint of the line, where the branches of superficial cervical plexus emerge from behind the posterior border of sternocleidomastoid. So the initial injection of 3 ml local anesthetic is deposited in the midpoint, followed by 7 ml. You must deposit in a fan-like manner, fanning. The goal is to achieve block on 4 major branches of superficial cervical plexus block, and deep needle insertion should be avoided. Mostly the needle should be inserted just like 1 centimeter or 1.5 centimeter, must be less than 2 centimeter only. That is mostly subcutaneously. Here what you will do is, in the midpoint between the mastoid process and the chachesnoid tubercle, you must inject the needle at the midpoint just by 1 centimeter insertion, not more than 1 to 1.5 centimeter. You must inject the drug there around 2 to 4 ml. and then redirect the needle, cephalad and choroid like fanning. You must deposit another 7 ml, 3 or 4 ml in the cephalad region and 4 ml in the choroid region. You must get the superficial cervical plexus block very easily. So complications of superficial cervical plexus and deep cervical plexus are here infection is common here in any other type of block. Here also infection is common if you don't sterile the area. If you do in under septic conditions, not in aseptic conditions, there will be definitely infection chances will be there. If you inadvertently hit the superficial structures there during fanning, there will be hematoma formation will be there. If you go deep inside, not more than 2 centimeters, there is a chance of pre narrow block. And there is a, if you don't aspirate and give, because you are giving more than 10 ml, the midpoint 4 ml, and during fanning around 7 ml, more than 10 ml you are giving. So if you don't aspirate and you just infiltrate, there's a chances of local anesthesia toxicity. Nerve injury is also inadvertently possible. So sometimes if you go more cephalad, there is a chance of subarachnoid injection and total spinal anesthesia also during the superficial and deep cervical plexus blocks. So these are the superficial and deep cervical plexus blocks. So coming to mandibular nerve block. So mandibular nerve block, this is many people will go for a mandibular nerve block, means they will go for intraoral approach. Mostly these intraoral approaches are blocking the inferior alveolar nerve or buccal approach or low gates approach. These are all other techniques. So we go for intraoral mandibular nerve mostly by the dental surgeons and the maxillofacial surgeons. But for our anesthetists, we will go for an extra oral approach, and that too with PNS guided mandibular block. It will be more accurate. If you go for a PNS guided, you can give directly landmark guided also, but sometimes you will miss if you don't find the perfect landmarks. You will miss the block. But in the PNS guided, you will definitely get the block very accurately. So mostly we require the PNS guided extraoral mandibular nerve block that we are discussing now. So mandibular nerve is a mixed branch of trigeminal nerve. It leaves the cranial cavity to foramen ovale and runs anteriorly to the middle meningeal artery. It divides into small anterior trunk which supplies the muscles of mastication and large posterior trunk which supplies sensory innervation to the floor of the mouth, anterior to the tongue and lower jaw. So mandibular nerve block is usually needed in mandibular surgeries. Mostly Komodo surgery, Komodo operation, where there is mandibular carcinoma, buccal carcinoma, will do all these mandibular nerve blocks. So mandibular resection in malignancies which gives good post-operative analgesia. So mandibular nerve block is very easy to perform, and anyone can perform even with PNS. It is most appropriate, most accurately we can get. Even in the landmark guided also, mandibular nerve block is very easy to perform. You can go for alcohol ablation of trigeminal also. So very easy thing, but as well as very complicated thing also. So advantage of extraoral mandibular nerve block is it can be done as a daycare bedside technique. The extraoral approach blocks all the sensory branches of the mandibular nerve. Use of nerve stimulator will improve the accuracy and may reduce the potential complications seen with the blind technique. The endpoint of mandibular nerve stimulation is the form of jaw jerk, which is easily visible. You can easily visible in any patient with the jaw jerk. And use of ultrasound for mandibular nerve block may not be useful as the deep nerves are surrounded by bony structures. So high, what can I say, is skill is necessary for performing the mandibular nerve block under USG guide. But for performing the mandibular nerve block in PNS guided, it is a very easy technique and very accurately you can block the mandibular nerve. So here it is the mandibular nerve. You can see this is the mandible, the mental foramen, and this is the condyle, and this is the coronoid process, and this is the coronoid notch. So the Howard landmark is the identification of the coronoid notch. This is coronoid notch. So our landmark is identification of the coronoid notch. Just you can access the mandibular nerve through the mandibular notch. It can be given with landmark technique. You identify the coronoid notch, insert the needle perpendicularly, hit the pterygoid process, and just redirect medially and posteriorly and inject the drug. So, but this is the landmark guided. It's not most accurate. sometimes you will miss the anesthesia, you will miss the now, or sometimes you will damage it now. But the PNS guided, you will the technique is very accurate, and you can get a perfect block and a very easy block also. So first of all, you must identify the coronoid notch. It is between the condyle and the coronoid process of the mandible. It's easily identifiable even in obese patients also by just to ask them to open the mouth, and you will find a little bit depression, that is the coronoid notch. So after the palpating this coronoid notch, 1 to 1.5 centimeter anterior to the tragus, we will see a little bit depression. It is the coronoid notch or mandibular notch. You should palpate it even in the obese patients also. Use a 10 centimeter stimulating needle. You insert perpendicularly to skin and look for the response. First, the PNS is set at 1.5 amps and redirect the needle bit cranially, and you can see the mandibular response. So here, what we will see is go perpendicularly just 2 to 3 centimeters anterior to the tragus. You will see the coronoid notch. Just go anteriorly by keeping the current at 1.5. You will find the mandibular twitches. We will see the video there next. So next to you, reduce the current to 0.5. So whether the response is coming or not. And so 1.5 to 1, and then reduce to 0.7, 0.6, 0.5. And if this response is there, give the injection. And sometimes go for 0.3. If there is response in 0.3 also, this is chances of intraneural injection. So the twitches must disappear at 0.3, and it will be 0.5 amps current. So at 0.4, it definitely disappear. So this is the right place where we can inject the drug. After injecting the drug, response will be gone. Always aspirate before injection, because it is a very vascular area. Inject around 7 to 8 ml of local anesthesia. That's more than enough. You can block the mandibular nerve. So it is a very easy method. It can be utilized for giving regional anesthesia for mandibular surgery. Very easy block. You can utilize it for your mandibular surgeries. And you can see the video here. You can see the pictures of the mandible when you insert the needle in the anterior part of the 2 to 3 centimeters anterior to the tragus in the coronoid notch of the mandible. You will find the pictures of the mandible. By decreasing the current to 0.5, you are getting pictures. And by even you decrease to 0.3, it should disappear. And if you have, the pictures are appearing at 0.3, that there's chance of the intraneural injection, which is a complication of the vein block. So these are pictures. You can see the movement of the mandible. So you see, this is the mandibular nerve distribution. So thank you. And if you want to discuss if you want to discuss, we will discuss about the blocks and all. You can share your comments on.
सिटो घड़ी वॉल्यूम बंद करें.
Are you getting? Am I audible?
Yeah, you are audible.
Yeah. So we can.
Can I make some comments?
Please, please.
Yeah, very nice presentation, Anil. I like to add some points here. It was very nicely presented. Regarding skull block, as you said, you have to inject at multiple points. But when they are using for awake surgery, usually they put the patient on the frame, so they are inserting pins. So you have to give bilateral block in case of awake craniotomies. Another thing is, when you are giving bilateral block, you have to be careful regarding selection of the concentration of the drug and volume of the drug, because when you give bilateral block, you require 40 ml of LA at least. So usually what we prefer is 0.375% ropivacaine. And in most patients, like 50 to 60 kg patient, it is not a toxic dose. Another point I want to make regarding scalp block, when you want to block get greater and lesser occipital nerve, especially in awake patient, you can ask the patient to get seated. So in sitting position, it is easier to block both these nerves in few seconds only. If a patient is sleeping, then you have to make the patient lateral and you have to change the position twice. Regarding cervical plexus block, whenever it is intermediate or deep cervical plexus, you will get phrenic nerve palsy for sure. So when if you are getting bilateral cervical plexus block, it may lead to bilateral phrenic nerve palsy. If patient is healthy, they can tolerate it, but the patient is if some patient has some lung issue like COPD, then it is difficult to become difficult to tolerate it. So be careful while giving bilateral, intermediate, or deep cervical plexus block. Regarding mandibular nerve block, sometimes I've observed we are using it regularly, and sometimes I've observed that even if you aspirate, you don't get blood. But if you are using PNS, I've seen that even if you are intravascular and if your needle tip is close to the nerve, you get the contraction. So when you inject the drug, there won't it will not lead to disappearance of the muscular response. So there won't be positive Raj test. Even if you inject 2 ml of the drugs, motor response will remain there. In that case, you have to be suspicious about intravascular injection. So make the needle end open to the air and blood will come in a few seconds. If you aspirate, sometimes vessel get collapsed and you don't get blood inside the needle or in the extension tubing. So you have to be careful because this is a vascular area, and if you are using bupivacaine and if you inject intravascularly, there are chances of local anesthetic systemic toxicity. So these are the few points I want to add. Otherwise, it was an excellent presentation. Thank you, Anil.
Thank you, sir.
Yeah, thank you, Dr. Anil. And any other participant have any question, then they can raise your his or her hand. So I can unmute that participant, or that participant can unmute herself, himself, and he or she can ask question. Yeah.
Hello.
If anyone,
Hi, good afternoon.
yeah,
Yeah.
tell me.
Hi, good afternoon, sir.
Yeah,
Actually,
good
I would
afternoon.
like to ask what kind of, what is the length of the needle used in the mandibular block? PNS needle, I'm asking.
Centimeters, we'll use the long needle.
Hello.
Yeah, Dr. Anil, can you hear?
Yeah, hi. Hello.
PNS we
Hello.
use
Yeah, madam. Once some problem is there in Dr. Anil's mic. Dr. Anil, hello.
am I audible now?
Yeah.
Yeah, you are
Hello.
audible. Yeah.
Yeah.
Take a
Uh,
long insulated needle more than 10 centimeters. And insert just 5 centimeters, not more than 5 centimeters. You will get the mistake.
Acha. So up to 5 centimeter, you will be able to hit the mandibular nerve, right? Okay. I actually in the video I saw the entire length of the needle inside in that video. So I thought whether it is 5 centimeter or 10 centimeter.
Small needle, but we'll go for a 10 centimeter needle.
Hello. Sorry.
Yeah, your voice is not clear, Dr. Anil. Some problem is there in your voice, some mic system or somewhere. So your voice is not properly audible.
In that this thing in that video, we used only 5 centimeter needle for a short.
Okay. Short needle. Okay. Thank you.
Thank you.
Anil, which drug you use for mandibular nerve block, and what is the concentration and volume of the
So we use ropin, sir, ropivacaine, sir.
and concentration and volume of the drug?
Concentration volume of drug is just around 7 to 8 ml, sir. Sir, for the post-op analgesia, we are giving 0.2% ropin, just 7 to 8 ml.
Okay. And do you give bilateral or unilateral? Suppose it is commando surgery. Will you give it bilateral or unilateral?
Been giving bilateral, sir.
Okay. Thank you.
Yeah, any other delegates have any question? Dr. Saji, someone asked some
Yes,
question on Messenger. Yeah,
yeah.
you can. Yeah, you
Am I,
can.
am I audible, sir?
Yeah, you're audible. Yeah, you can.
A very nice practical session. It was excellent, good coverage. But I just had one or two few doubts. Hetal sir made it quite clear about the concentration, but Dr. Anil had said about 0.75%. It's basically a sensory blockade, but how come we need such a large concentration, especially for scalp, where you need lots of volumes, even if it is one single nerve, supratrochlear and supraorbital also. I think you don't, that's my thought, it's just a sensory block. Less than 0.5 of anything would suffice, that's my thought. That is one thing. And the other thing is about the mandibular nerve block. I usually do the oral ones, but sometimes there will be trismus and there will be little difficulty. But this block, to give it in an awake patient, will they tolerate that? The track has the parotids and the facial nerve all going close by. I just have some little doubts. I've never done it, but it sounds very good. Sounds very good with the PNS. So some thoughts on these two things, concentration of locals in scalp blocks and about the mandibular nerve PNS approach that condyle route, just one or 2 points on that, sir.
Yeah, Dr. Anil.
Anil, you are not audible.
Am I audible, sir? Now, am I audible, sir?
Mic is
Yeah,
not clear from your side. Not very much clear. Initially, during presentation, it was fine.
Sir, right now, am I audible, sir?
Yeah, better.
Sir, for the scalp block, we use a very low volume, sir, for just 2 to 3 ml only. So the 0.75% of 2 to 3 ml will not cause the motor thing. It will just give the sensory thing only for the awake craniotomist. And if you go for the total surgery should be done in the awake, this block, we will go little bit more volume.
Okay. So using higher concentrations, will you get more double the time? I'm just my small thoughts. Just by using high concentrations, will you be able to get a lot of time, double the time?
Yeah, the time duration will increase. That's why we are using this Huawekin. The time will be increased, and the volume required is less when you use the.
Yeah. Volume is definitely less. But if you're going for total bilateral scalp, as Dr. Hetal said, you need a lot of volume in a bowl, mixed, calculated, diluted with some additives like if at all needed, adrenaline or dexamethasone and all that with that low. I think but I never thought that by giving high concentrations you will get double the amount of time. Suppose for a long neurosurgery, we usually do it. We at the start we do, and after 6 or 8 10 hours, if it takes a long time, our surgeon is a little slow. So towards the end of the surgery also, I'll just give a patch up kind of block, so that patients are comfortable in the post-operative period. I'm very fond of scalp blocks at the start of neurosurgery. And if it's a long surgery, 8 hours, 7 hours, 8 hours, I'll do one later in the session also, later in the session, So how about the other thing, the doubt about the mandibular nerve block? Is it tolerated by the awake patients, the needle, the PNS needle going through the cheek? I just wanted to ask Dr. Anil's thoughts on that. It's a little deep, and wouldn't they cry out loud? Or you give some ketamine or something, just a little bit.
The patient can tolerate because in PNS we will not. What we can do is.
Your voice is not clear, Dr. Anil. Some voice is not properly audible.
1 minute, sir. Wi-Fi is-
Yeah.
Yeah, because you're doing it, you'll be able to tell much better, because we just don't want to hurt patients before they're big or commando operation or something. So if they can tolerate, it's worth trying. It's worth nice. Yeah.
Yeah, by the time he sets the mic, I will answer your question, Dr. Saji.
Yeah,
In
sir.
commando surgery, we are using this block, and we give this block after induction of anesthesia only.
Yeah.
But
Yeah. Okay.
remember
Okay, sir.
that you induce the patient with if you when you induce the patient, you use propofol and scoline. So
Yeah.
once the effect of scoline wear off, then only you can use the PNS. Otherwise,
Okay.
you won't get any response. So you
Okay.
have to be careful. You keep the plane of anesthesia deeper. So after coming out of scoline, patient will not have problem. So keep the
Yeah.
plane of anesthesia deep, and only after giving the block, give whatever long-acting muscle
Relax.
relaxant you are using.
Very nice,
So
sir.
this is
Very
the
nice.
point
That's
you, yeah. So
that's
this
good,
is
sir.
the point you need. Yeah.
That's a good technique. That's a very nice technique, sir. Very nice, sir. Okay, sir. Thank you. Thank you, sir.
Thank you. Thank you, sir.
Yeah. Any other question from delegate side?
Anil,
Yeah,
will
I
you,
think.
Anil, will you like to add something in it? Are you using it in awake patient, mandibular nerve block?
Using an awake patients, sir, not intubated.
Anil, you are not audible. Yeah.
So we are using in awake patients too, sir. Hello,
Yeah, you are audible.
Okay. Okay.
sir. We are
So
using in awake patients
is
too,
it
sir.
after? Yeah. Is it after some sedation or?
A little bit sedation, sir, but mostly after post-operatively, we will use for post-operative analgesias. The patients are tolerating, sir, here, but we'll give just dexmedetomidine as a awake sedation, and we just give mandibular nerve block.
Okay.
Okay.
Okay, doctor.
Okay.
Okay. Thank you.
Yeah. Okay. Thank you, Dr. Anil, for such a nice presentation. I have it's very informative as well as practical presentation, and we learned lots of new things from your presentation. And actually, Dr. Anil is our faculty in our RAD 2024 workshop in Delhi on 6th and 7th April 2024. So I have shared one screen that theme of our workshop that we are working mainly on how to improve the periphery practice or rural anesthesia practice. So in that we are planning to perform various now blocks, PNS as well as LR guided now blocks from head to foot, from mandibular now to the ankle block, various anesthetic block as well as solve and post-op analgesia blocks. So for that, if anyone is interested to join that workshop, they can enroll themselves by registering through our official website. And that fees also we kept very economical because majority PGs and other anesthetics newcomers also can attend our workshop. So it's for consultant, it's 5,500 rupees, and for PGs, 4,500 rupees. And before that workshop, we have scheduled various topics webinar because during workshop we directly listen. Sometimes we can miss some point, or sometimes we don't know something will go up beyond our head. And if we properly prepare, we'll do homework before conference or workshop, and afterward if we'll attend the workshop, then it will work, or you can digest more from workshop. So for that we have like webinar also we have kept. So different topics webinar, all these topics webinar our faculty will present on different dates. All these are different dates and topics of our webinar that before actual presentation on conference or workshop day, we will announce some sort of webinars on that particular topic, and whoever are interested to join webinar or whoever are coming for conference, they can attend their webinar, and after webinar they will just, it's like a pre-medication before surgery, so it will be much smooth to digest the conference or workshop topics. So all faculty also will get pre-medicated, as well as our conference delegates also will get pre-medicated. That is the main aim behind this webinars before conference. And third thing, we have extended our early bird registration. We have crossed 50 plus registration till now, and we have limited our registration till 100 delegates only for workshop because of all capacity. So whoever wants to join for that upcoming workshop, and they can enroll themselves as early as possible. So up to 15th March, it will be for consultant 5,500 rupees, and for PGs 4,500 rupees. Conference and workshop fee will be there. And afterward, it will be 6,500 for consultants and 5,500 for PGs will be there. Okay. And if any query, any confusion is there, they can contact on my number 95106-92160, and they can visit our official website gashdaevents.com also for further detail and for further inquiry. Okay, thank you all of delegates as well as our faculty, and a special thanks to Dr. Hetal Vadera sir, moderator of our that webinar. She gave such nice inputs and practical inputs. So I'm very much thankful to all faculties as well as moderator and delegates. Okay, now we are ending our session, and we'll meet on next Wednesday or Thursday. We'll release our flyer on webinar on WhatsApp and Facebook group also. So whoever wants to attend, they can attend our webinar. That webinar will be there on sciatic and femoral nerve block, PNS guided sciatic and femoral nerve block, and lateral femoral cutanous nerve block. Okay, thank you so much.